Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Lynn Carroll, Chief Operating Officer at HSBlox. Lynn, welcome back to the show.
Hi, Matt. It's good to talk to you again.
So, Lynn, I think as you might remember, I always like to give my guests a chance to provide more of an introduction in terms of who they are and what they do. So since it's been a couple of years since you've been on, I'll give it to you and the floor is yours.
Yeah, sounds good, Matt. Well, certainly appreciate the opportunity to talk with you and the audience today. I am the Chief Operating Officer at HSBlox, as you noted, and our business, which we started in 2017, is focused on providing capabilities for payers and providers to scale and expand their value-based care footprint. Particularly, we delve into the areas of administration of contracts, as well as payment issuance and regular ongoing reporting initiatives for the different types of value-based programs that we see in the market.
And so given that value-based care focus, kind of how have you seen the market evolve over the past few years? Because it's, I know value-based care remains a hot topic, but then there's also questions of how widespread adoption actually is.
Yeah, it's a good question, Matt. Certainly things have accelerated, but as we probably know in healthcare, acceleration is an interesting word. I think we have continued to see federal programs, and even just recently in March, we had a new ACO Flex announcement from CMS for furthering primary care initiatives within the value-based space. Things are progressing. I would not say they're moving at light speed, which is an accurate observation, I think, in general across the marketplace. But what we are seeing is a pickup in what are traditionally probably referred to as pay-for-value types of programs and different types of incentivization making their way into commercial programs as well as some direct-to-employer programs, which I think bodes well for the continued progression of a value-based marketplace. But certainly, a good portion of driving toward value-based care has been from the federal government. Certainly, CMS has made a lot of initiatives prevalent over the last several years and continues to do so with its recent announcement on ACO Flex. Yeah,
so I think kind of a couple different areas to dig into, and I'm kind of interested to pursue that commercial side a little bit because it's, I think as you noted, CMS has been the primary driver, but how are the commercial models coming into the market, and kind of what are some of the options that you're seeing?
Yeah, it's another great question. So on the commercial side, things as you might imagine are all over the place. There are traditional pay-for-performance style programs. There are also programs based upon activity bases. So some of those types of activities are now incorporating health equity components under some of those programs. Certainly some of the leadership in that area has been done with Medicare Advantage. But on the commercial side, we have seen an improved focus on health equity in community-based organizations being brought into the fold as folks try to understand the patient population, i.e. member population, in a more holistic manner. And certainly bringing in non-traditional approaches like community-based organizations and social service agencies, aligning primary care with behavioral health. Some of those initiatives are starting to make their way into the commercial side of things.
And that's a very interesting move. And it is, I think, kind of aligns with some of the regulatory changes that we've seen, focusing on that community-based care. So what are some of the paths to collaboration in that regard?
So I think one of the things that is required is a transparent type of an infrastructure that can bring more alignment between payer, provider, and certainly these third-party types of organizations that address more street-level health equity, SDOH components. As you probably well know, a lot of those organizations in the market do not use traditional healthcare transactions. And a number of those organizations have unstructured data as well. So trying to capture and mix traditional healthcare claims and administrative data, as well as some clinical data along the lines of HL7 fire transactions, mixing that with unstructured data that's gathered in the form of questionnaires and other form-based approaches that occur in both behavioral health as well as in the social services area is an interesting evolution that we have seen to try to create a more holistic 360 degree, which is probably overused term, view of the patient.
And so you raised a great point about mixing data from different sources. So you're just kind of pointing out that those community players might have unstructured data. So is structure being brought down to their level, or is it that the unstructured data, we've gotten better tools that can interpret and then create structure around the unstructured piece?
Yeah, so it's certainly the latter, which is in most of the use cases we've been involved with. Information has come in the form of free text. It's come in the form of images. It's come in the form of PDFs, for example, and digitization of that data, bringing structure to unstructured or unformatted types of data and mixing it into traditional data sets to be able to create a holistic view, and also the ability to then incorporate that unstructured data by giving it structure so that analytics can be performed across those data sets is a big piece of what we have seen happening. And we are certainly involved in a number of those use cases to bring that data to the fore for these needs that are kind of focused on non-traditional paths for care management as well as intervention.
So, as you're kind of exploring that, who's leading the charge in interpreting and then acting upon that data? Is it the payers? Is it the kind of traditional care delivery organizations, or is it some combination of those two and others?
So certainly the payers have interest in that information to understand more of the holistic risk of their member populations. And I think, again, when you look at the care management side of it, it is good information to understand from a care coordination standpoint, not only for the logistical part of care coordination, but also to allocate resources appropriately and understand who are high touch, high needs types of patients where more time can be devoted. And then certainly to identify those that may be more self-sufficient and possibly require, a once or twice a year check-in, as opposed to somebody who may need more ongoing assistance and coordination.
And kind of as you're going through that, are there technology tools that are helping with that assessment to augment what individuals are doing, or kind of what direction are you seeing in that regard?
So typically what we have been involved with have been use cases where we've had to apply natural language processing to bring structure into that type of data. We then commingle it with traditional data sets, claims and administrative data to create a longitudinal health record. That then is something that is often shared with either care management teams or care management organizations that might be in the business of coordination and patient navigation strategies to get care delivered more prospectively and in the right location by the right practitioners at the right time. And so those more commingled data sets, providing that type of structure and a more holistic view, seems to be where a lot of folks have focused effort over the last, I'd say, year or year and a half.
And kind of, you keep coming back to that coordination piece. So do you see an increased willingness to bring together those different groups who maybe weren't always working together? And if yes, kind of what additional challenges do you still see that need to be kind of tackled and barriers removed?
Yeah, I think one of the drivers is certainly some of the risk models that are out there. I think when you look at organizations that have maybe traditionally only had upside sharing or have had incentivization, and now being either delving into or putting their toe into the water with regard to some degree or some corridor of downside risk. Now it becomes more imperative to not only understand where leakage might be occurring or where referrals might be going, but also to understand how to make use of non-traditional network participants like the community-based and social service organizations. And certainly, as I mentioned, ACO Flex earlier, the federal government is certainly driving primary specialty care alignment and looking at bringing into the fold in some of these arrangements more coordination and more alignment between primary care, specialty care, and these ancillary types of provision.
Yeah, so that raises a great point of, as you said, as groups are taking on not just upside benefit but the downside risk, they, I think as you said, they need to have a better handle of what's going on and better control. So, where do we stand in that adoption of both up and down risk? Because I know kind of earlier you were alluding to the fact that pay for performance or other, it sounds like more kind of beneficial style models are fairly prevalent. But again, long-winded way of saying, where do we stand in that progress of getting adoption of both up and down risk? So it drives, you really need to drive that change in behavior.
Yeah, it's a good question. It seems to be sort of all over the map, depending upon different regions or different markets. We have had discussions in the last few weeks with folks who are in, full delegation mode where they have, 30 or 40 ACOs, for example, that they have total cost of care programs in place with. That's probably, more the exception than the norm. I think in a lot of cases, there has been increased focus on what is being incentivized under the pay for value types of programs. And there also has been some more proactive nature in looking at what can be incentivized to ensure that it occurs, things like annual well visits and things that, are proactive in nature. I think we will see as these models continue to evolve and we get into more downside risks, there'll be an increased interest in what artificial intelligence and different types of AI approaches can do to help understand what some cost structures might be, particularly when you think about things like new drug treatments or new protocols coming on market, trying to understand where I might be at risk for these new treatments and what those might cost is one of the things that I think we can see some potential for AI. But if I look all over the market in terms of where people are at, it's kind of all over the place. So we do see some of those, as I mentioned, total cost of care contracts. Those seem to be more the exception than the rule. We do see certainly, and this has been driven by CMS as well, specialty carve-out scenarios in the area of MSK and CKD, things that are requirements for understanding not only getting the right folks involved in treatment up front, but reducing the time to accurate diagnosis and therefore more prospective treatment versus taking a longer time to figure out the exact diagnosis and therefore potentially having an increased challenge for the patient.
Yeah, no, I think a lot of confluence of factors there that, as you said, are driving a lot of positive change. And for those of you just joining, I'm talking with Lynn Carroll from HSBlox, and we've been talking a lot about where risk and value is going on the commercial side. And Lynn, you mentioned a couple of times, the new ACO Flex and kind of other movements that CMS has taken recently. So given that those are still pretty new, do you want to give us a little bit more background in terms of what those programs look like and then how you anticipate those continuing to advance the value-based care ball?
Yeah, sure. We certainly think that ACO Flex will hopefully drive continued formation of ACO approaches, certainly in some of the rural and underserved markets, which of course is a espoused goal of the ACO Flex programs. Particularly trying to continue to build infrastructure and ability to deliver a full continuum of care in underserved areas around FQHCs, and the ability to allow FQHCs to incorporate more either social programs or better coordination, particularly as it relates to behavioral health, and also to invoke coordination with specialists on a more effective and timely basis in those underserved markets, which I think will have some impact not only for the Medicare and Medicaid population, but some spillover effect into either underinsured or employed, but underinsured types of individuals in those markets.
Yeah, no, I think as you said, kind of focusing on those areas, definitely, populations that don't always get that attention. And, just kind of given the experience with some of the other ACO models, what do you think is going to be a reasonable kind of period of time to make an actual assessment of the impact that's being made? Because to some degree, I have a worry that people want to evaluate it after just a year, maybe a year or two, when maybe that's not going to be enough to actually see the adoption of change or give time for that change to really seep in and make a difference.
Well, I think that's a good point. As we started the conversation today, we talked about healthcare not moving at light speed. And, while I think everybody who's been in the industry for a number of years, and certainly patients who've always been by the very nature in the industry, things don't tend to move as fast as we would like them to. And there's probably good reason for that in some ways. But one of the things that is always important is to give yourself an appropriate amount of time to evaluate if something is effective or not. I think there's a lot of rush to believe that we're going to be able to hone in a lot of the predictive modeling as well as generative AI, and all of a sudden have a panacea of information and shorten treatment times in the next year or two, for example, which obviously is not going to be the case. Same goes for these types of programs, which is that continued evaluation. Most CMS programs usually have a 4 or 5 year period on them for evaluation to understand the efficacy of the program and its continuance. So I think, certainly expecting to within a year or even two is probably an unrealistic expectation.
Yeah, no, and I think that's a great point. As you said, a lot of those models do have that 4 to 5 year initial time frame. And, especially if you're going into groups that haven't been a part of or a full participant in the adoption of change, and they are constrained on resources, it might take even longer, especially because I think as we saw, the initial ACO models, you had some of the early adopters were ones who had already been, going down the value path, so they had a leg up. But the others that were really getting going for the first time, it took time for the real shifts to be observed and quantified.
Right, and it's a great point. And it's why Flex, I think, was announced, which is to try to bring additional folks into the fold and provide opportunities for the underserved areas to also participate in these more value-based, prospective types of models. I think one of the things that certainly has driven a lot of interest in value-based programs and continues to do so are two obvious things. One, COVID, where fee-for-service put a halt to a lot of reimbursement. And recently, the cyber attacks on Change Healthcare that created a scenario where folks could not get paid on a traditional fee-for-service basis because claims could not be submitted and therefore reimbursed. Both of those types of examples give payers and providers a reason to consider putting more prospective types of models in place that aren't based solely on volume. And certainly advantage from a payer perspective is to have a better known cost structure. And on the provider side is to have a more assured or known revenue stream based upon a more prospective type of model rather than a volume-based model.
Yeah, no, that's a really, I think, a key insight there, which, as you said, is, if you are having a prospective payment system and then you're reconciling either shared savings or or downside risk later on, you have that more steady revenue stream to be doing ongoing operations with. And it's almost kind of looking at as your income and then potential bonus at the end of the year, which I think a lot of people on an employment side would understand because you see that on a personal level.
Yep.
So kind of, Lynn, you've mentioned kind of AI a bunch of times throughout the discussion so far. And given that AI remains one of those hot button topics in healthcare, kind of what's the actual state of these AI tools to be helping enhance value-based care, and kind of what actual benefits have you seen out in the real world so far?
Well, I think they're certainly continuing to improve. It's probably a healthy debate to understand that are they to the point where they can be relied upon is probably a good question. But certainly they are very applicable, and certainly the digitization of data area that we talked about. They are effective in also helping to model large data sets. To be able to look for more pattern-based and therefore more prospective scenarios. From a purely generative standpoint, we see there can be some applicability in generating optimized care plans within the care management realm of things, but there are some dangers. Certainly, the quality and health of the data that is applied to the models. Is it complete? Is it accurate? What's going in? There will need to be some oversight with regard to full applicability of these types of approaches. I would guess that we will see the government get involved in validating some of the predicted outcomes of these programs that use a lot of AI. To understand empirically, what is the degree of accuracy of the predictions. There will probably be initiatives to continue along the lines of the interoperability initiatives to also make sure that we can clean up data. So interoperability, one thing, clean and useful data, another. I think we will also see that in a lot of the cases, there will be concerns about making sure that there isn't an inappropriate bias with regard to certain populations, either because of a lack of data or a lack of incorporation of appropriate data to understand are some of the models skewed along different social lines or different economic lines that may not be 100% germane to what's being done from an AI or machine learning standpoint.
Yeah, and I would say some of those points you just raised just reflect a growing understanding around, traditional limitations within the healthcare system. In particular, kind of that bias area. So what do you think, or what information you think, or kind of critical analysis would help to not only just raise the awareness, but actually drive change that helps to eliminate the bias within the data and approaches?
I think part of it is looking at what is the completeness of the data set and what are the factors being incorporated from a variables standpoint. So I have to understand not only is there the traditional administrative and clinical data, but then there are certainly these external data sets that we talked about a little bit earlier in the program, which come from other sources, non-healthcare sources, in fact, in a lot of cases. That look at geographic factors, look at employment factors, housing factors, and things that are on the ground level where folks may be located or what may be happening in the environment that they are located in. And so I think the validation of the data sets and the appropriate factors will be a key initiative in widespread adoption, but certainly trust. And a big part of gaining trust in these types of programs is certainly patient education and provider education with regard to what the benefits are of AI-driven care management programs, for example, and what are some of the potential drawbacks of these types of approaches.
Yeah, and kind of thinking about that trust issue, I definitely agree with you. That is going to be very essential, for everybody involved using tools. So to help, either enhance or actually develop that trust. What lessons do you think can be learned from some of the recent examples that have been highlighted, where an AI-based system, whether or not it was actually AI, but that's a different debate, drove potentially negative consequences. And one of the things I'm thinking about is, kind of the reports, I guess it's a few months ago now, of an AI or ML system that helped drive rejection of prior authorizations or claim review on the insurance side. So it's, how do you see kind of the ball moving forward from there to overcome and show that the systems have been refined and are not capturing those same concerns?
Well, I think one of the cautionary areas is to certainly continue to involve, human oversight of these types of programs. And some of the randomization of validation is an important scenario, that there is still face-to-face interaction, particularly for cases that have either high cost or have polychronic nature to them. So certainly you can look at, less chronic and less acute types of cases and feel relatively comfortable with a lot of the predicted outcomes and or paths for the patient. But I think there continues to need to be oversight over either what would be a higher cost type of program, or certainly individuals that show as polychronic with regard to what is being authorized and or approved, because certainly we don't have enough empirical data to validate longitudinally for a long enough period of time. And we certainly haven't had the opportunity to tweak and adjust the models as we move forward. I think we'll continue to see large language approaches become certainly more advanced and more accurate as we go forward. But can't keep 100% of everything in the AI camp at this point in time. It's not mature enough to be able to rely 100%. It's certainly a great aid. It's a great directional tool. And in some cases, highly valid. But certainly as we get into more polychronic cases and more expensive cases, it certainly makes sense to continue to have human intervention to understand what's happening with a patient. And certainly that face-to-face component cannot be overridden with regard to these types of individuals who may have 2, 3, 4 indicators with regard to polychronic conditions.
Yeah, no, and I think that's a great point, that it's, AI is not a cure-all. And, but as you said, it can be definitely an augmenting tool that helps just improve and enhance the existing care and interactions that can occur. And unfortunately, I think that's going to have to be the final parting thought, because believe it or not, we are already out of time. I want to thank my guest, Lynn Carroll, for a great conversation today.
Yeah, thanks, Matt. It was great to be here. Always enjoy it.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.